Here. Good to meet you. Thank you so much. I don't have to take that card, but I will. I will give you. I will.
Everyone. I think it's still a challenge like this hybrid events. I mean, you have to be ready. It's good that we start in time, right? People online should be in time right now. Well, welcome everyone. And thank you for joining us.
Recording in
the
progress.
Session called Unpacking the Expansion of NCD Best Buys and Their Investment Case. What does it mean for national NCD prevention and control, which is co-hosted by NCD Alliance and Vital Strategies. My name is Paula Jones, and I will be your moderator today. And for some announcements for the people online, for anyone on Zoom needing assistance, please use the chat function to message anyone with the title technical facilitator in their name. And before we get started, I still have a few technical notes to explain. If you would like to contribute a perspective or idea in person, you can just wait for our queue until for our question and answer segment after the first panels. We'll have two panels. We'll allow time for the audience and the venue to speak. And for those of you joining on Zoom, please feel free to use the chat function, which you can find at the bottom of your Zoom window. If you would like to post a question directly to the speakers, please do so in the question and answers box. And this session is being recorded for documentation purpose. And lastly, we are also streaming live on YouTube, Twitter, and LinkedIn to reach a larger audience. So welcome everyone. It's a pleasure to be here in person, to be here in Geneva after quite a few years. It's kind of, there's a time lapse, like how many years has it been? Like since before the COVID pandemic, it's my first time since 2019. We'll have I'm sure, a very exciting session. I'm particularly excited about Appendix 3 of the NCDs, because I think we have been like the tough negotiations. Everyone who has been there, and I see some people in the room that has been around the negotiations of this Appendix 3 for the NCDs action plan. It has been challenged to negotiate them, but they are really an amazing tool, and we are even happier to see that they have been updated now, and that's going to be what the part of the discussion today. And to start, before we start, we have we'll start first with Dr. José Luis Castro with some opening remarks. He's the president and CEO of Vital Strategies, so welcome you here.
But thank you, Paula, and good evening, everyone. It's good to see you all. It's an honor to join you today, this evening, to unpack the expansion of the Best Buys, our best weapon against the world's #1 killer, non-communicable diseases. Now, you're here today as you recognize the benefits of the WHO's Best Buys. They are proven, cost-effective, efficient strategies that have the power to prevent the non-communicable diseases that account for over 40 million deaths this year. That's 74% of all the deaths around the world. Now, I will not preach to the converted. Instead, I'd like to talk about the barriers that continue to thwart global progress toward unleashing the full potential of these Best Buys. I'm talking about the commercial determinants of health. Tobacco, alcohol, and ultra-processed food contribute to the most common chronic killers: heart disease, diabetes, cancer, and lung disease. And the industries that produce and market these products are more interested in profit than in healthy people and healthy communities. These industries use their considerable resources to influence government to reject or soften restrictions on their products. These commercial interests are antithetical to the goals of public health policy. This alone should disqualify them from joining the table to share their so-called solutions. Now, we can amplify this message by introducing more explicit recommendations against corporate influence in the WHO Best Buys, specifically Appendix 3. Now, why is this important? Because corporate influence worldwide has been identified as the main reasons why Best Buy's implementations fall short. according to a recent Lancet series highlighting the pernicious influence of these commercial determinants. 4 industry sectors: tobacco, ultra-processed food, fossil fuels, and alcohol account for at least 1/3 of all global deaths. This commercial influence is pervasive, confronting governments with financial enticements, legal battles, and other ways to limit the reach of policies such as food warning labels, marketing restrictions, and taxes on harmful products. Now, the good news is that the public is increasingly supportive of these policies. People want warning labels on foods. They want regulations to curb the relentless marketing that targets children and youth, pushing them toward unhealthy behaviors. They want restrictions on tobacco marketing that reach children near schools and online. Taxation is the single most effective weapon that we have to curb the consumption of harmful products, and it is supported by the public, especially if that revenue is directed towards public programs. Vital Strategies is proud to be a long-term partner with the NCD Alliance, convening our collective strengths to elevate NCD prevention and control. And when it comes to pursuing the most effective strategies to prevent non-communicable diseases, let's place the interest of people and communities above the commercial interests and not be derailed. Thank you to the NCD Alliance for partnering on this important topical event. And thank you to all of you and to today's speakers for the ongoing work that you do to protect the health of millions of people. Thank you.
Thank you, thank you. Well, it is exciting to be discussing how to move forward with that. So the next, still in the same setting agenda here, I will invite Dr. Bente Mikkelsen. She's the director from NCD department at WHO. Welcome here, Bente.
Thank you very much. And let's see, is it possible to okay. So is it possible to see the screen here as well?
Can we see the screen here, the presentation, or we can just see ourselves?
We see ourselves.
We see ourselves.
We are
Look
quite,
nice, huh?
yeah, I would say so. It's possible without, but since it's a possible, can you please come and help?
If we can see the screen that is.
No, yeah, great.
Oh, there.
And then,
There you are.
and how do we change the screen?
Maybe you ask them.
When I move, I can, okay, excellent. So thank you very much. So much for technology. Easier than the best advice. Okay. So my name is Bente Mikkelsen. I'm very pleased to be here with you tonight. And thank you again to Vital Strategies and NCD Alliance to always focus on the most important things on NCD, I would say. So if you give me the next slide, please. Nope. Thank you. So last year, we had the biggest NCD agenda ever for the World Health Assembly. We had 10 items. And one of the things that was the most important was that member states realized that we did not, in the current sort of business as usual, really had a course towards reaching the SDG 3.4 to reduce the premature mortality with 1/3 before 2030. So we suggested an implementation roadmap, and that was a result of 6 regional technical consultations, and we got an agreement from the member states on this. So when you look at this screen, it's the directions of the implementation roadmap. So it might seem obvious, but I think this is the first time the countries says themselves we have to be in the leadership. We need to adapt what is important for us towards our situation, our national context. So that was number one. So they wanted it to be clear that the acceleration of national response should be based on the understanding of the NCD epidemiology, risk factors, and the identified barriers and enablers at the country level. The second was as important, and that was actually that they asked for help to prioritize. It's not possible to implement 5 by 5 with all the beautiful packages that we have at the same time in the country. And actually, I have to say, this is almost like family, right? Sometimes we are our worst enemy because we all travel to countries with our own packages, and sometimes this is really difficult for countries. So I think with the strengthened and empowered government that really want to see the change coming up, this is very important. So the last one was the request, the huge request for data, but not only the request for new data, but also the commitment to act on existing data at the country level. So they wanted to see the risk factor, this disease mortality, and they wanted to act data driven. So this is the big sort of umbrella. This is the 3 directions. And in this picture, the appendix 3 needs to be read. So also the starting, the address by José fits very well, because this is actually about feasibility. In some countries, the commercial determinants is so strong that maybe the only thing countries can do is to choose another best buy. I'm not saying that we should give in for these forces, but it's all about the country leadership, right? Next slide, please. So we can be happy or not happy about this wording. I think beyond our community, nobody understands what the Appendix 3 is. But I want to bring you back to the history of this, because it was a very important appendix to the NCD Global Action Plan. So another thing to remember is that you have to read this into the NCD Global Action Plan that is extended until 2030. So the Appendix 3 doesn't live its own life. It is embedded in the principle, the 6 objectives, into the global monitoring framework with its 9 targets and also 26 indicators. Important to remember, right? So the Appendix 3 was first agreed already in 2013, and we had a revision in 2017, and this is the 3rd revision. So all the discussions, okay, what was the sort of the fallout of the methodology needs to again go back to the principles on how we do this revision. So it's also very important that it's a menu of policy options. So I can tell you before the discussion that probably will happen tomorrow, we have over and over again, member states, they ask us, we don't want this intervention description because we cannot do it in our countries. Or our country. And we have to tell them, well, this is a global menu of actions or interventions. So you can choose among them. You don't have to use all of them. You can adapt them as you please. So when we explained that, most of them, all of them, no Slim has withdrawn their criticism. So at the moment, fingers crossed, it will go through tomorrow, right? So it provides guidance on effectiveness and cost effectiveness of selected population-based and also individual interventions. That is also very important. So this is both on prevention, it's on management, and it's also on health system strengthening. And that is something that is very often forgotten. And when people now very much eager to work on PhD, UHC, they start to ask us, well, you should start to think about inclusion into PhD. And I can very proudly tell them that, yes, it's been part of the Appendix 3, and it's been part of our thinking actually since 2013, and it's a very strong part of the NCD Global Action Plan. So I would almost say that we are one of the most integrated agendas with the pen package, with the hearts, with the salt, the shake, and all this. So the initial list of cost-effective interventions included, as I said, in 2013, 2017. I put some links, and we are happy to share this with NCDA, so you can put it on your webpage or whatever, and please use the whole package. Next slide, please. So the next thing to see and understand and to take into account is how do we update? It's not like a random update. So we consider intervention from new WHO normative and standard setting products that has come into place since the last update. So the way we did this was that we called for them across WHO, 3 levels, all the different technical departments. And maybe next time when we do the update, we could call a little bit broader, more like what they do in the essential medicine list, where we also call for candidates, let's say. I think that is something that has come true when we have had our hearings. It might have changed something, maybe not, we don't know, but I think that would be a good thing. Then the second is to refine formulation of existing intervention and reflect WHO guidance. So that can be, for example, because they have been slightly changed or that we have new data. And the third one is to update and add intervention based on agreed criteria and new and available scientific evidence on impact. So this is the way we have done it. It is a full technical document that you can look into if you want to see the full technology or methodology, sorry, also technology and focus here. And we have people in the room like Slim Slama, who has been leading this process. Wave your hand, Slim. And also Philip Mehus, who has been the person that have done all the cost effectiveness analysis. So any questions or deep technical sort, please jump on them in the break. I leave the room. Okay, next slide, please. So what is the changes when we look from 2017 and until today? So in 2017, we had a total of 88 interventions, including overarching and enabling actions, and 39 of them had cost-effective estimates. In 2022, we have in total 90 interventions and 22 overarching enabling actions, and 58 interventions with cost-effectiveness estimates. And also, very importantly, this expansion of the number of countries. In 2017, we only looked into 20 countries, and we grouped them in 2 regions. Today, we have 62 countries that is part of the exercise, and it's grouped in all 3 income categories. You must have noticed that, for example, the NCDI Commission were discussing this. Is this pro-poor or is it not? Is it a skewed number of countries included? And we have tried to mitigate that in this round. Next slide, please. So out of the 58 interventions, 28 are considered to be the most cost-effective and feasible for implementation, the so-called best buys, compared with 16. Overall, the majority of the proposed intervention have an average cost-effectiveness ratio of less or similar to 5,000 international dollars per healthy life gain, representing a good value for money. Next slide, please. And this is a slide I really enjoy, because as much as we load the best buys, the 16, it actually took away a little bit of the attention of all the both best and good buys. So it didn't really include also some of the health strengthening, some of the management interventions. So it became a little bit of a misunderstanding that it was only these 16. So we have tried our ever best now to pay attention to the whole list of interventions. And this is rather technical, but my take on this is that if you want to invest a little bit more than the 100 and up to 5,000, and if you invest 5,000 international dollars, you will be able to include as much as 86% of the intervention in the updated Appendix 3. And on this point, I want you to know that we are not thinking about one intervention. Coming back to the 3 strategic directions, what we would advise is that the country, based on their own epidemiology feasibility, could do a pathway of several interventions. And there have been, for example, University of Washington with David Watkins have done an exercise showing that if you combine several of these interventions, he chose some others, but anyway, 55% of the low and middle income country would be able already in 2025 to achieve the SDG 3.4. This is very important to remember, and that gives me a lot of hope because it is possible. We cannot do everything, but we can choose. I'm very soon to be ready. Next slide, please. I know that you're a bit impatient, but I think they're coming here also to learn about this. Yes. So I'm not going to go through this list, Paula, but this is the 28 of the best buys. So you will see that they are sort of scattered around all the 4x4. And remember, this is the NCD Global Action Plan. So it's the 4x4. We do have also best buys for mental health, and we do have best buys also for environmental health. So at the country level, the member states expect us to use the packages from all these different areas. Next slide, please. And that's the last one, I think. Well, so we did what we call a big investment case, and you can see that we have made the case that this is really return on investment. I don't want to go into detail. Next slide, please. So the tracking of the implementation was a question asked to me. So we do periodic assessment of national capacity for NCD prevention and control, and you recognize, I think, the monitor. So this is 850 or so data points, and we can track and report country progress through the monitor that we do every second year. And of course, we have published also technical notes that you can look into for each of the intervention. And following World Health Assembly 76, we will update indicators tracked to align with the intervention. And also very importantly to know if the resolution stands as it is tomorrow, we are also asked by the member state to do a regular update when data is available. And I'm so happy about that. And they have added that we should present the result back at the World Health Assembly 80. We know that some countries don't want to have it into the governing body. Let's see what they will decide when we are closer in 5 years, because it's some of the countries want, others doesn't want. So we don't know at the moment. Next slide. That must be the last one. Yeah, so this is the decision. I just told about it. Next slide. And that is, oh, okay. So we will communicate. So as you can understand, this is very technical. So we plan to publish it as a publication. We will, of course, publish it online and so on, but we will do a lot of different communication products, and we will work with civil society, especially NCDA, who is very helpful in this, to make this understandable and really dwell into the use of the whole Appendix 3. So it doesn't stand alone as single intervention, but really as useful information to countries. So I think then, next slide is thank you, isn't it? Yes. No, you were very
Well, thank you, Bent. I think that was an excellent presentation of Appendix 3, and I think it makes all of us optimistic. And also aware that there's so much work to be done, right? From a perspective, coming from civil society, as a civil society advocate, I always think that we are not doing enough, but I think that's the spirit, depending where you stand, right? So we have an excellent panel now, and I will call the 5 speakers here, and then I will have questions for you. We have like our Thailand and Philippines, which are our heroes in public health. I mean, from the old times in terms of like reinvesting in health and taxing. So I would like to call like, I hope I get Dr. Krausorn from Thailand. You can take a seat, please. I will call all of them and then we clap to all of them at once, okay? Yes, you can just, Dr. Nika from the Philippines, Nandita from Vital Strategies, Kenneth, yeah, and Professor Anna Gilmore, okay. Oh, you have all the titles there on the screen already, so we'll save time with the presentations and want to just welcome all of them so that we have more time to hear from them. So I will start here with Thailand. And I mean it when I say that you are our heroes, because in the old days in tobacco control, I mean, the example of Thai health and how you reinvest in your tax and reinvest money for health purpose, health promotion, it's really fantastic. So Dr. Chryson, Thailand has pioneered in the implementation of many prevention interventions from Appendix 3. It shows the return on investment. So the Thai Health Promotion Foundation also receives its revenue from a 2% surcharge of excise taxes on tobacco and alcohol, two of the NCD best buys. So based on our country's experience, what guidance is needed to support countries in identify those prevention interventions from Appendix 3 that will have the most impact in their national and regional context? And also, I think Thailand has been a champion in universal health coverage, and it's currently a co-sponsor of the decision on universal health coverage that is being discussed at the World Health Assembly this week. So what do you think is needed to ensure that health promotion and prevention are seen and treated as essential elements in this continuum of care and therefore of universal health coverage? How has Thailand approached this nationally? Thank you.
Thank you, Paula. Hi, everyone. I'm Dr. Grayson from Thailand, and thank you for your question. Thank you for asking for about hero. I'm not sure that Thailand should be the hero of public health, but we will try our best. For your first question, that how we approach, how to identify which in the Appendix 3 to be picked up and to be make sure that it would be the best or the most impact for our country. We can have with the field approach. For example, we use the epidemiologic data from, for example, the Empower of the country profile in the report that all of the countries that in the state party of the FCTC should have this country profile. And then we have learned a lot from this Empower. For example, that in the Empower, we learned that in Thailand, the cigarette is still cheap. People in Thailand still very affordable to buy cigarette. Even we raise the tax up to 78.6% of the tax, but it's still affordable for the people to buy cigarette. It may be because of the increase of the retail price of the cigarette, still not catch up with the disposable income of the people. So that points to the policy that we have to further increase the retail price later. This is one of the Empower that help us to do the information and then to pick up what intervention in the Appendix 3 that we choose to use. For the alcohol, we use the alcohol status by the WHO that to find out what is the appropriate to pick up. And we find out that this provides us a lot of information about mortality, alcohol related with the road traffic, alcohol related with the cirrhosis. And then we found out that this is very helpful for us to make sure that we pick up with the most impact one. We try to use in the Appendix 3 that, for some example, that try to control the consumption, try to control the availability, try to control the sales of the alcohol, especially during the long public holidays, long festival that many people drive and drink. So we try to prevent the drivers and to make sure that we can reduce or prevent the alcohol-related traffic injury. And this is one of the most important things is we try to, especially the blood alcohol concentration limit via the sobriety checkpoint that also in the Appendix 3. So for the alcohol, we put almost every intervention in comprehensively and make sure that something is work, something is not work in the context of my country. But we just try and then maybe we'll be work in the later. Also, Thailand has a national survey, and that should be as a third strategy that we need information a lot. We did the national survey maybe 2 or 3 years once to make sure that the National Statistical Office will help us to know the risk factor of all NCD in the countries. And then with this national survey, it's quite large samples, so we can drill down to the provincial level. And then with this data, we will work with the local government and the governor of the provincial. By law, we have the multi-sectoral provincial tobacco control committee and also the provincial alcohol control committee. And both committees are chaired by the governor. And the provincial chief medical officer also be the secretary. And this is what we pick from the appendix 3 and to use. For your second question, right? UHC is one of our principles for Thailand, and we use primary health care to approach the UHC. We initiated primary health care in Thailand since 1970s by the district health system. We try to develop the district health district hospital and also sub-district health center all nationwide. And we integrate all service, include primary care, into the primary health care. That include prevention, health promotion, disease surveillance, treatment, rehabilitation, even the palliative care into primary health care. And we put that into the district level, so that's why we use the primary health care to be the core concept to the UHC. And of course, NCD is the most loaded problem for the primary health care in Thailand. About 70% of the outpatient is NCDs. So we focus a lot in the NCD to make sure that the Ministry of Public Health, the National Security Health Office that provide the budget work together and to make sure that it's the effective coverage of the, even we try to do our best, the effective coverage of diabetes and hypertension is still very low. And by detection and treatment is not enough now. So we focus more on primary prevention of the NCD. And with this primary prevention, we do the aggressive more, but at the same time, the industry, commercial determinant also put some more aggressive also. Last 2 weeks, we have the general election of the countries, and the tobacco industry also put some effort, quite aggressive, to lobby the tobacco industry to be lifting the ban of the e-cigarette that we declare. And some of our political parties during the general election also advocate this. So quite problem of our country also. So we do another thing is we generate the sub-district fund, and this fund is joint invested by National Health Security Office and the local government to work together with this fund and to make sure that it's proven effective in managing primary prevention of NCD through the community level interventions. So in conclusion, Thailand integrate the whole range of the NCD services in the primary health care and primary prevention at the community level.
Thank you.
Paula.
Thank you, Dr. Kryson. So my next questions will go to Dr. Nika from the Philippines. Well, the Philippines Universal Healthcare Act has become a global reference for the acceleration of universal health coverage at the national level. What support has Appendix 3 provided in the design and implementation of this legislation and its policies? And you are also a co-sponsor on the decision of universal health coverage that it's being discussed. So based on the Philippines country experience, how do we ensure that health promotion and prevention are seen and treated as essential elements of the continuum of care? It's a bit of the same question as for Thailand. Thank you.
you, and good evening. Here? Okay. So I'm here to also share with you a lot of the things that we're doing in the Philippines. So of the initially identified 16 from 2017, we've actually successfully implemented 12, and 4 are actually ongoing. The Annex 3 and all of our global commitments we take seriously, specifically at the Department of Health, and we use that to inform our local discussions and decision making. So in the Philippines, we have a tobacco excise tax, we have graphic health warning laws, we have sponsorship bans for tobacco, we have no smokings in all LGUs. We actually even award local governments and give them cash incentives if they implement them in their public places. We have mass media restrictions, age of access restrictions, regulation by FDA, and even regulation on flavors for tobacco. For alcohol, because of the success of the tobacco sin tax, a few years later, we implemented an alcohol tax and even some restrictions about advertisement to young children. And we've actually also implemented just recently a trans fatty acid administrative order. So we've yet to do the legislation, but that's the next way to go. Along with this, we also implemented, a lot of it also came from COVID, but we used that as a trigger to promote active transport, green open spaces, physical activity, and all of health behavior, the directed campaigns. Upcoming commitments and plans also include other things that we've yet to have. Then we have 28 more to bring in, but we do have plans for like salt restrictions, front of pack labeling, and actually stronger tobacco and substance use products, because we do have our own issues with industry lobby who have tried to weaken some of these reforms before. And then of course, on top of the service delivery imperative, cervical cancer vaccination, screening, and the access to meds. A lot of this is made possible not only because of the guidance from WHO, but also because of our universal healthcare law, which we implemented in 2018. So this law set the Philippines to a radical vision of what it wants to reorient the whole health system into a primary care centric health system. And the icing on the cake is that the tax we get from sin tax is the one that is funding our UHC. So we actually have around $2 billion US dollars per year from sin tax. And that has been what triggered a lot of the investments for health facilities, health workforce, and all of the organizational expansions of the UH. We're not perfect, we've still yet to be there, but that's been the impetus for a lot of the things that we've been able to do for the health sector. In terms of learnings, I think the first that I wanted to share was really we couldn't do this without the help of non-health actors. It couldn't be only DOH alone, doctors, nurses alone. We needed the support of legislators, and we're very lucky that we have very strong legislators to fight with industry with us for all of these things. Sometimes we lose, but we still remain to have our allies in Congress. We also have a very active civil society network in the Philippines, and we do have good relationships with our professional societies, our medical societies, because of our practice guideline program and evidence-based practice guideline program. So the second learning I wanted to share is that in this active engagement with non-health actors, the value we bring in as DOH is that we are the ones who make sure that we promote evidence-based interventions. And that's where all of these guidances come from. We actually, as part of our UHC, have health technology assessment being implemented in the country, but that's still in its infancy. So guidances like this who already do the cost effectiveness for us make it very easy for us to implement a lot of these things. Annex 3 specifically has been used by another reform under the UHC Act of the creation of a Health Promotions Bureau to be the one to focus on enabling environment, schools, workplace settings, and also the healthy behaviors in some campaigns. So we were laughing earlier about one of our undersecretaries actually doing a belly dance campaign. So that was when the time that Zumba was world phenomenon. So walk the talk is really something even our officials do. They even lead in front of media these Zumba dances just for NCD. So that's the level of commitment that the Philippine Department of Health has. And I guess the second question was about how do we ensure health promotion is part of this discussion in UHC. The answer is we're very explicit about it. We redefined UHC. UHC in some debates is really just contained to social health insurance, cost coverage, population coverage. But UHC in the Philippines is under 4 pillars. So it included enabling people to be healthy, and that's where all the health promotion, social determinants work happen. Protecting from health risk, and that's where all of the like pandemic preparedness related work and even medicine security work comes in. Caring, as I mentioned, the primary care centric approach, and the strengthening of the health system. So it was very explicit in our strategies, in how we define what UHC is, that it's the whole package. We're not just talking about one thing. When we talk to UHC, UHC really is an overhaul of the overall health system. And I guess the last one is that it's been a hard journey, but that fidelity to that UHC vision is also, I think, one of our good practice. I know many ministers know this, that there's the pressure of the vertical programs and how they sometimes disrupt changes to UHC. But we've taken, I mean, it's a work in progress, but we're taking active account that when we talk about integration, we don't lose the fact that our old historical programs are there. But we maintain fidelity to our vision of a primary care centric integrated system, regardless of what the disease is, and that is being included even in our output, like our guidances, our trainings, and our investments. So I hope I was able to showcase what the Philippines has been doing. We're a strong proponent and a strong pusher of UHC for everyone, and rest assured NCD is always part of our UHC plans.
Thank you so much, Nika. I think now we have had like two good country experience, but it's not like that everywhere else. So I'll move forward to Nandita to talk a little bit about well, we know that the evidence shows and that fiscal policies and taxation on unhealthy commodities are very effective there, but still it's hard to implement it in many places. So when it's very uneven worldwide. So what are the major barriers to that, Nandita? And what are the best practices and opportunities that you have been working on through Vital Strategies? And how can we better communicate it to the general public, to policymakers, and to be able to to overcome the barriers? To you, Nandita.
Thank you, Paula. Good evening. So the idea that taxes are not well implemented is well established. WHO in 2018 reported that tobacco taxes were only implemented in 38 countries at the time, covering 14% of the global population. And this is tobacco taxes for which the evidence has existed much longer. But there is also good news and progress. The idea of health taxes now is well understood. And we're seeing momentum for health taxes globally. So 50 jurisdictions and countries globally now have a sugary drinks or a junk food tax, and momentum for alcohol taxes is also growing. So good news along with the continued uneven and patchy implementation of taxes. There are several reasons for this. Lack of evidence is not one of those. And what we would argue is that the reasons for poor implementation of taxes is really social and political. On the social end, we know from the behavioral sciences that for action, there needs to be a sense of urgency and a belief that the risk is real, imminent, and that it can be severe enough. And we saw this with the COVID-19 pandemic. Literally overnight, health systems were able to mobilize around a threat. Tobacco, unhealthy diets, alcohol don't seem to have that sense of an existential threat in quite the same way, even though the threat is just as real. And that is one part of the problem, the apathy around implementation. Another, of course, is political and corporate influence. This has already been described quite well, so I won't belabor the point, but the threat of corporations, as well as the misinformation sowed by them, tend to be barriers. So what have we done at Vital Strategies? what we've done in partnership with many others in this room, included global partners, local partners, multilaterals, governments, is essentially seek to shift the narrative at the political and social levels. We've done this through media campaigns and communication strategies that draw from behavioral science, but then ultimately test in every context in which we work. What I'll provide here is 5 lessons that we've learned through our own evaluations as well as the work of others. First, media campaigns and communication efforts are vital for tax implementation. Of course, this can vary. Some political contexts may not require public support in quite the same way, and that's a special, and a different consideration. But in most contexts, in the absence of public support, in the absence of communication efforts, tax proposals have failed, and there's systematic evidence now to show the difference between when they've passed and when they have not. And an example of this comes from Cook County, Illinois, where in the absence of this kind of public support galvanized by media campaigns, the tax essentially caved in with the pressure from the industry. An interesting finding in the literature also is, even when tax proposals fail, but there's been sufficient communication around the introduction of the taxes, we find that there is an effect on behavior. So what that means is even the conversation around tax proposals can have an impact. So important to remember that. Second, this communication, public support, and advocacy needs to continue well beyond the passage of the taxes. The groups that don't want the tax in place will fight it even after it's implemented because they don't want it spreading to other jurisdictions. So the pressure has to be maintained beyond. Third, message framing matters. The industry knows this well. For instance, describing a sugary drinks tax as a grocery tax, which it was not clearly. So message framing, how we describe a tax, is significantly important. Linking the tax to social benefits, we find, is a very powerful way of building public support. In our surveys, we've seen about a 20% bump up in public support for a tax proposal when how that money is going to be reinvested is made clear. How exactly that money is to be reinvested can change depending on context and political priorities in countries. So it may be water fountains in one context, or it might be UHC in another, and it's really important to tap into what are the local political priorities. And finally, data is key. Data can really demonstrate where the public stands and counter industry arguments that the public does not in fact want it. And in fact, there's even been evidence that retailers can be in support of taxes, which is something without the data might seem unreal, but in fact, data can make the case. Therefore, studying public opinion, documenting it, advertising it, making it clear is important. So in conclusion, the barriers to tax policy are often social, political, and social approaches steeped in science can play a powerful counterforce. Thank you.
Thank you, Nandita. That was so. Communications is key always, but we are still explore more on that, on the the highlights and also the barriers to implementation with our next speaker, Dr. Kenneth Connell. What do you think are the main highlights from the current Appendix Sub-3 update? How can it support the work in the CARICOM countries, and why is it important that it becomes an alive document? And please talk a little bit also about the main barriers in the region. I think Nandita explored a little bit, a lot from the points of from the perspective of communication, but I mean, trying to implement the Appendix 3 measures there, how is it in your real life experience?
Sure. So thank you, Paula, and thank you for having me on this panel. In the pre-panel discussions which we had outside, I didn't warn you I was going to be frank in my discussion here. So I plan to stick to the script, but also my co-panelists have changed my script somewhat. So the best buys for small island developing states, such as the Caribbean, are not just the best buys. They're really the only buys for those countries. In other words, there is no other choice but the WHO best buys. And the Appendix 3 as a live document really takes me back to a statement made by one CARICOM leader in my country, Barbados, when he said that, you know, all of the gains made in our post-independent societies could easily be reversed from the impact of the NCDs. And that was powerful. The reason behind it simply is we cannot afford treatment. That's why I said we do not have the luxury of not implementing the best buys. You have countries that are struggling to make basic human right requirements. You have countries that are coming out of a pandemic and due to various geopolitical influences have been placed in poor positions or poorer positions than before. And of course, you have countries that depend on tourism for their livelihoods coming out of a pandemic that are still suffering from that. And let's not mention that we are now entering the hurricane season. So let us be very clear when we speak about best buys for the CARICOM region, they really are not best buys there. They are really the only buys. Let me go in particularly to Barbados and some of the other Caribbean countries I will cite by saying that we have strong non-health determinants. I'm not going to say the social determinants we discussed outside, or even the commercial determinants. I'm going to call them the non-health determinants. The reason for that is because there are some determinants that we are unpacking that we're not even sure of the impact that they will have on our societies, like cultural determinants. Many of you in the room may not know that if you are from my country and you say anything about you do not eat or you do not like sugar, you could be deported. And if you say that you do not consume alcohol, you will be deported. So these are cultural influences. We are now entering carnival seasons around the region, Barbados, Trinidad, Jamaica. To go to a fete or a party and not have an alcoholic drink, I mean, it's just not heard of. You're changing a whole culture and behavior of societies that, you know, will only happen over time. And then, of course, we have those non-health determinants that place special impact on small island developing states like the Caribbean. And these are really industry. You know, you don't have several sources of income. Many of our countries import almost all of what we eat. Food security is an issue. Food security became a big issue for us when COVID-19 started, when we realized supermarket shelves suddenly stopped offering some of the products that they offered before. Then all of a sudden you realized, well, we are not as secure as we think we are. I remembered when the barriers or the borders were closed initially, some people in many countries say, let's keep them closed. And then we all look at each other and say, well, where are we going to get food from? So these are real issues, huh? And when we speak about things like front of package warning labels, we don't kind of have the strength to change industry because we're just a drop in a very large pool. So these are real issues for us when it comes to WHO best buys and Appendix 3. But let me say to the audience here, hopefully does not include any ministers of finance. It's speaking a different language. For too long in health, we have been speaking the language of health because that's what we're experts at. And for too long, I've been attending meetings with not like a friendly audience like yourselves, but in an audience that's really just looking to hear what is the evidence and how much does it cost. Imagine sitting in a meeting with a minister of finance in Jamaica, for instance, and making an argument about the number of lives saved if you reduce the HbA1c by X, or if you reduce the millimeters of mercury, or if you have, and he's looking at you like, what is HbA1c? Because the only thing he's thinking about is how is this cost effective? Because I have to budget so many different things, show me the evidence. So that's the one thing, show me the evidence. And the second thing is, show me the most recent evidence. Don't tell me that this is the evidence from 10 years ago, or cite the latest or the last document produced by WHO. That Minister of Finance needs a living document that is carefully referenced, that he can speak to his electorate, because he's a minister, right? And respond to them in a very tangible way. So the WHO best buys, Appendix 3, the fact that they are reviewed and it's a live document is critical. It's critical for all countries, but it's even more critical, I will argue, for small island developing countries that lack the capacity to carry out that type of research. In another forum, we had a discussion about the fact that what was happening in the COVID-19 pandemic was so poorly documented, the successes in small island developing countries such as the Caribbean. And I made a retort and saying, well, what are you going to do? Are you going to focus on documenting your success? Or are you going to focus on saving lives in the middle of a pandemic? You have to prioritize. And if you have limited research capacity, data capacity, then you have to prioritize. So the fact that these are evidence-based live documents is really critical. So I'm going to stop here where I ended.
Oh, okay.
And where I started, sorry. And by saying really, the Appendix 3 is of extreme importance to us in the Caribbean society because we don't see it, or we cannot afford to see it only as best buys. They are the only buys for us because we cannot afford anything else.
Yeah, thank you so much. Well, I think this leaves us to the next speaker in this panel. We have another one right after, but Anna Gilmore, she's one of the leading authors of the recent series, The Lancet series on the commercial determinants of health. And I think it will wrap up very well this panel here, including, for example, I think Cornell, he raised an issue there about culture and individual behavior. So I would like you, Anna, to approach that and commercial determinants of health as a barrier to Appendix 3 implementation. The floor is yours.
Okay. So hopefully you have already heard that we've recently published this series. There were some copies outside and there's a few here. Please take them because we have been slogging them around in our rucksacks and we don't want to carry them anymore. And for those that are online, you just Google Lancet series commercial determinants of health and you will find the information. So really what this paper is trying to show to us is that the issue of NCDs, and in particular the issue of the problems we're having trying to get the best buy policies in place, reflect the commercial determinants of health, and that the problem we're dealing with is not a problem of a few unhealthy commodity industries and their products. It's a system problem, okay? And these issues are linked up, so we need to look at it as a whole, okay? And what we do in this series is we map that problem and we produce a model of that problem. And I really think that model can help us, there's so much going on here, but that model can help us tease out what the issues are and how we can address them. So one of the key problems we face in trying to get these best buy policies implemented is commercial sector practices. And those are diverse practices. We divide them up here. So key is political practices. So the way they lobby against policies. And in fact, in other pieces of work, we've actually now got a taxonomy and a model of that, which you can then use. Scientific practices. So actually the way that they undermine science, both science about the harm of their products, but also science about the particular policy that you're trying to get in place at the time. So we absolutely need to address commercial sector influence on science and reshape science in the public interest. Then what about financial practices? You know, 40% of multinational corporate profits end up in tax havens, okay? That's the equivalent of one nurse's salary every second. So there's a huge issue here in affordability of healthcare and funding for these interventions. So we've got to understand those practices. That's one key way, and address those practices and do that across the board. The other reason we struggle to get these policies in is that corporations don't just influence policies, they influence upstream policy infrastructure, okay? So what they have done is they have put in place systems of policy making that make it really hard to pass public health and environmental policies. And leaked tobacco industry documents show this quite clearly, that tobacco companies brought together a whole coalition of different industries from diverse sectors, food, chemicals, and so on, to try and set up systems of policy making which require stakeholder consultation early in the policy process and an impact assessment that takes a cost-benefit analysis approach. And this evidence is from Europe, okay? But almost every country I talk to, so many countries I talk to, they have the same systems in place. And you need to be aware that this evidence shows that industry pushed for those systems to make it harder to pass policies in the public interest, to make it harder to pass policies that would protect health and the environment. So we need to recognize that this whole system of policymaking is stacked against us, okay? And think about not only how do we play that game while that system is in place, because we can, but also how do we change that system? And even more upstream than that, we have our political and economic system. And actually, really over the last 50 years, what we have seen within that system is, an emphasis on deregulation, on working in partnership. And those have had huge impacts and also made it incredibly difficult to pass public health policies. And of course, it will come as no surprise that actually the major corporations, again, have pushed for neoliberalism. And so we have to think about all of these things. We need to move away from this singular focus on GDP. That really does stymie our ability to progress. So the key message is this isn't just a few issues, this is a big system problem, and our lives will be much easier if we address it as a system problem. And I think there are a few sort of minimum things we need to do. So, we need conflict of interest policies. We need policies on engagement, or more importantly, non-engagement with industry. We need to avoid partnerships with vectors of disease. I've said we need to look at how we ensure science functions in the public interest. We need to look at how we manage reputation management. Industries spend a huge amount of money in managing their reputation in corporate social responsibility. That's usually tax deductible, but really it's just a form of marketing. And all that investment also makes it harder to pass public health policies. So those are just some of the, what I would call sort of overarching or enabling actions in the words of Appendix 3 and best buys that we need to consider. And I think another really important thing to think about is to identify what not to do. What are the worst buys or the bad buys? And that is really saying no to voluntary or partnership approaches to policy making. Yeah. The evidence is they don't work. In our area of NCDs, that they don't work. So that's the first question, Paola. Oh. And then it was this individualization. Industry has solved idea to governments that these are lifestyle problems, they're problems of individuals, and this should be dealt with at an individual level. Okay, so there's a few things to note here. First, of course, industry is trying to do this to shift the blame on itself, away from itself. And the other reason it wants to do that is if we focus on those downstream individual level interventions, those are less effective and far more expensive, okay? It's far better to go upstream and tackle this at the policy level, okay? Tackle the real drivers of these diseases. And that is exactly what the best buys are. So we need to sell those to governments because they are hugely cost effective, as we've heard, in fact, cost saving. The second point about this is the corporation's ability to shape norms in this way and really trick governments into thinking that these are simply problems of individuals reflects their power. And what we've seen over time is an increase in corporate wealth in the private sector, so in corporate power, and a stagnation of public sector wealth and power. There's some really powerful graphs, if you look at the World Inequalities Report, which shows that that wealth in the public sector in the rich countries is now zero and negative in some cases. But actually wealth overall has been going up, but it's now entirely in private sector hands. And that really challenges the public sector's ability to address these issues. So we absolutely need to think about this, and finance ministers need to understand that and address that. I think another really powerful piece of evidence is that despite the harm of NCDs going up and sales of tobacco, alcohol, fossil fuels, ultra-processed foods going up, the effective tax rates on those corporations registered in the US has been going down over time. So there's huge scope to increase taxes. And that is the way we're going to have to address commercial power, because what they're doing is they're causing huge harm, but the cost of those harm are externalized to us and to states. And only by taxing corporations can we address those externalities and rebalance that power. So taxation is really incredibly important here. Yeah. And the last thing I think, I mean, the question was, what we need governments to do really is to act in the interests of the many and not the few. And really that should not be too much to ask here.
Thank you, Anna. Well, I think there are so many things to be covered. I mean, just like it's even really challenged to make any like to sum it up, because each one of the windows that you open there, the panel, you can have a really in-depth discussion about
Yeah.
some of the subjects. So I will highlight, I think it's kind of, well, let's watch out for what not to do, because the list of the to-do list, it's already in the Appendix 3 update. So I like when you raise the problems around like voluntary agreements and so on, because that's pretty much always the solution that is offered instead of doing something more effective. And also the thing about the, the individuals feeling guilty, the industry not held accountable, and the externality is not being paid. So I think that's also an important key message. And I don't think we lack evidence, really. We do have enough evidence to do the basic, and we are not doing the basic. So putting my advocate hat again on, I think we are too slow. There's so much to do. We know what to do. If we just did the basics, just taxation of alcohol, ultra processed foods and beverages and tobacco, and I mean, and fossil fuels will be great. But we are, on the contrary, we are giving so many incentives. In Brazil last year, ultra processed foods became cheaper than real food. And that's very, very serious. And that's very dangerous from a public health perspective. And the incentives are getting they're just growing for this type of industry. So I think we need to get more outrage about it overall. We will not have time for questions for this panel because we still have another panel, but I will ask you to stay here because the panelists will be here for the reception right after, so we can still have conversations about it. Just like, thank you so much. So without further ado, I'll start calling our next panel. Which is about also two areas about the future of development of Appendix 3, making the investment case for NCD and mental health service, and discussing the upcoming menu of cost-effective intervention on air pollution. We know these are the two areas that we haven't been discussing as much in the NCD. Right, arena. So I would like to welcome Stefan. Where is Stefan? Please, Stefan. He's a member of our Views and Our Voice Advisory Committee from Kenya. Sarah from United for Global Mental Health, please come. Nina, head of Health Clean Air Fund. Welcome. So let's welcome all of them. And again, you have a proper presentation on the screen again. So I will start with Stefan. Stefan, you also as a person with lived experience, but also as a young advocate, welcome. Leading your own civil society organization to advance public health in Kenya. How can governments and other stakeholders ensure that the lived experience can inform their priorities as they look to implement Appendix 3? Do you see a role for community voices and actors? And the Appendix 3 methodology, it's also been used to develop other menu of policy options, such as on mental health, oral health, and potentially air pollution as a major NCD risk factor. As a person affected by many of these and leveraged on your own experience in Kenya, what does it mean to you and people living with NCDs globally? Please, Stefan. Floor is yours.
I see. All right. Hi, everyone. I hope we are doing well. So that's a lot of questions, and I'll try to answer them within the time frame. So again, my name is Organised, and I was born with childhood obesity. So having been born with childhood obesity, the expectation is that as I continue to grow, that I continue to develop comorbidities if this is not managed. Now, back where I was born, which is at a small village back in Kenya, we didn't have a lot of access to healthy foods anyway. There was a lot of trans fats was naturally available in the food. unhealthy food, which you just talked about, and ultra processed food is much cheaper than actual food. And in fact, from where I came from, finding soda is much easier than finding clean drinking water. So already you begin to see that even if my parents and my community really understood that, you are born with childhood obesity, and this is the things that we can do to help you improve on your lifestyle, they could not, because this is very systemic, this is very top down, and especially the majority of the people who are affected by non-communicable diseases come from this kind of setups where they might even want to do something about it. They can't because of the situation of the day and because of what financial capacities and other social determinants of health that affect their lives. And so when I'm looking at this and looking at the first question on what does Appendix 3 mean for us as persons living with non-communicable diseases, but also how can governments and other stakeholders ensure that this lived experience informs priority, I'd really want to sort of start from the point of designing and prioritizing. So we have Appendix 3, which documents a whole lot of best buys and things that we need to do. But we also know that the capacities of the governments that we work in might not be able to implement all of them at the same time. And this, the decision on what to implement, especially when it comes to non-communicable diseases, I believe that also strongly falls into really bringing the people living with non-communicable diseases to give you what is the most urgent need. What is it that, if addressed today, would actually begin to have a lot more impact? And then our role then becomes really in terms of designing and prioritizing the national focus on how they'd want to implement Appendix 3. And then I'll move to the second point, where after that design process has happened, I see ourselves as people living with NCDs as people who help contextualize the recommendations given at Appendix 3 in terms of taking them from the document itself and now bringing it to real life experience and seeing this is how it affects us and this is how it could actually translate it into our local context. Because otherwise, if we want to implement the same thing that is being implemented in Mexico, in Brazil, in Canada, and we're living in Kenya and the context is very different, then at the end of the day, we don't end up having the desired outcome. And then after we've done that, I see another key role for us being engaged in the monitoring and evaluation process. Because what usually happens and what we've seen with governments when implementing such strategies is that they'll start to do, they'll say, oh, we commit to do this and we're gonna start working on this. And at the end of the, the period that they committed to be able to do this, they'll just go and report on what they did, as opposed to having developed a clear monitoring and evaluation framework at the beginning to see, this is the 5 things that we need to do, and this is how we are tracking them, and this is how we'll achieve them. And us as people living with NCDs, it becomes almost an important role for us to be, engaged towards that development and sort of follow through of those processes. Ultimately, I see our role as gatekeepers, but also see our role as the people who keep the government in check. Because otherwise, and the industries as well, might I add, because otherwise they just roam around. So, and then we say that we'll do this, but they'll come with their nice language because they have nice language, and then the government quickly shifts the priority and focus. Then coming to the second question on methodology that has been used for Appendix 3, and talking to the point of, this is now being used to develop other policy documents. So for example, in the mental health, oral health, and air pollution, potentially, as the question asked, The question was, as a person affected by many of these comorbidities, and I am, and leveraging on lived experience in Kenya, what does this mean for people living with non-communicable diseases, not only in Kenya, but also globally? And I think three things come to mind here. This is a tried, tested, and very well documented sets of strategies. And for a very long time, governments use the excuse of, we don't have the tried and tested, and we need a case. Can you develop for us a case? In this time, we already have the case. We already have the evidence developed. We already have the solutions put down, and we know if we invest this much, this is the return on investment. So for us, one of the things that I see that this indicates, it indicates that there is already a tried and tested formula, and so we do not have to reinvent the wheel. A lot of us as various countries and governments fancy being the first to do our own style of things, but when the problem is this big and this global, and the work has already been done on the problem already, we really do not have to reinvent the wheel. We have to move forward into rolling the wheel, moving into the implementation. We don't have to do square wheels like this. When the wheel is already round and it moves, roll the wheel and let's go.
Absolutely.
So that is the other thing. And then I also see this as something that for us as people with NCDs, it sort of isn't the burden in terms of following up when it comes to policy, because the majority of the work has been done, and it has been done with a very incredible group of scientists, experts, technical working groups. And so most of the time when we go to advocate at the policy level, the question is what work has been done? And then when you present it, who has done it? And when you present that, is it live? Is it updated? Is it recent? Can we use it in our context? But with the best buy, the fact that it's continuously getting updated, we already have a document that continues to live, which means that when we go now, and this would be even the call to governments in the House, is that the technical work has been done. So the conversation about the technicalities of the work, that shouldn't be part of the issue. The suggestions are already there. Again, we need to be rolling the wheel and moving towards the implementation. Rather than continuously focusing on, oh, this is the problem, this is a problem, let us now start moving to the implementation. And then finally, when I saw the question earlier on, it was like, it gives us hope. It really does give us hope, because if the work has been done and the suggestions have been there, and we know that if this is done, this is the outcome, we have some hope that if it was actually implemented in our countries, and if it was actually implemented to tackle specific issues, we know that this is the result that we expect. And often the result is we live longer, we live healthier, and things improve, as opposed to at the moment when things, especially for people living in NCDs, is very hard.
Thank you.
So that would be it for me at the moment, and thank you very much.
Thank you, Stefan. So let's go for it and hold governments and industry accountable, and listen to people living with NCDs and engage them. I'm going now to Sarah about the cost-effective policies on mental health following the political declaration and NCD, Sarah. Few policymakers are aware of this, and few countries have integrated this guidance in their broader NCD strategies. So what is needed to raise awareness about the need to integrate mental health servicing within the NCD implementation? And this menu of cost effectiveness policies on mental health include many recommendations. So for countries with limited resources that might need to prioritize, at the end of the day, all of them have to do, what are the considerations you think countries should need to have when they need to prioritize interventions? Thank you, Sarah.
Thank you very much. Thank you very much to everyone who's invited us to be here. So the NCD Alliance, of course, and to vital strategies, and really commend the work on the Lancet Commission. Extraordinary piece of work, report. So yes,
Yeah.
here it is.
Yeah.
I think you've all been sitting an awfully long time, and this is an
Yes.
NCD's meeting. So could you stand up for 1 minute?
I've been standing
give
all
a
the
shake.
time. See, I'm giving the example.
Brother, for yourself.
Yeah, good.
Thank you. And so I just wanted to start. The first question was why, how do we try and engage people on mental health and NCDs? So I just showed you. Hands up everyone who's been affected by an NCD or has a friend or a family member who's been affected by an NCD. Okay, good stretch. Stretch those legs. What about for mental health? Keep your hand. Yeah, second hand. Right. Okay. So I think on that basis, it's pretty clear when you're trying to raise awareness of the issue, start with a human being. You've got two people with lived experience who are brave enough to talk about that here. So I'm brave enough to talk about my lived experience on mental health. Stephen's been brave enough to share his story. Not everyone is brave enough, but I think what's really changed with the pandemic, with what happened with COVID, is that many, many people stepped forward and were brave enough to say, actually, I'm really struggling. And I'm struggling myself, or my family is struggling. And many, many of the health ministers who frankly were not talking about mental health before COVID are now talking about mental health. And I think that's probably the same in many places. I'm seeing lots of nods, also good for the physical health. Keep yourself nodding. So when we're trying to make the case for action, what we start with is the human. And everybody has lived experience of some description. It is so pervasive. NCDs, as we've all talked about, mental health, as we've talked about. So start with the human and connect on a human level. So when you go with your Appendix 3 and your list of cost-effective interventions, please start with the human. I think the second point to make is integration. We can't do these things alone. When I was looking back at what I'm reflecting on my own experience as the child of two parents who've survived cancer, it's really important to remember that people come with a physical disease, but they also come with mental health needs at the same time. And who hasn't felt concerned or anxious if they've been diagnosed with cancer, or even just waiting for the answer to that, what will happen to me? The same if you're going in for surgery, the same simply if you're taking a family member or a loved one to find out if they have an HIV or TB, it's a huge issue, and it's a physical and a mental health issue at the same time. So we work very hard to promote integration. You don't have one or the other, you have both hands. And the work that we've done, for example, is to show that if you integrate mental health services and support into, for example, TB or HIV programming, you can reduce cases and deaths. So in the case of HIV, you could save nearly 1 million fewer cases of HIV, around 900,000, and 14 million fewer cases of TB by 2030. Now, I'm sure all of you could say the same things for NCDs. So it's important to inspire people with what could be, with the visions for success in the future, not just the return on investment, which is nice, but the humans, both hands. You were asking me what interventions you prioritize. To be honest,
How to.
Sorry?
Or how to.
Or how to. I'd say that's very country and context specific. There is a wheel that's now can be rolled. And there are obviously things that we know about that help mental health. And there are basic treatments that exist. There are basic talking therapies like CBT that people have talked about. But as an organization, I feel quite embarrassed to be sitting here and not, frankly, to have my colleague Ives from the Philippines sitting here in my place, or my colleague Aviwe from South Africa. Because we as an organization work across what's called the Global Mental Health Action Network, and we represent over 2,500 and growing people from 130 countries. And we work with governments, with civil society, and most importantly, with people with lived experience. And when you ask them what matters, what intervention will work for you, it will be different in different places. And respectfully, the question implies that governments are not doing what they need to do on mental health. And again, I'd say it's changed. So this morning, the Commonwealth had a whole session on mental health and youth, and it was exciting. And what governments was lining up to say is that we are trying to do things right. Rwanda was there talking about what they're trying to do. We had colleagues from across the Caribbean. We think the Healthy Caribbean Coalition is just fabulous, and we're constantly promoting their work. There is real progress being made. Pakistan has decriminalized suicide. So has Ghana. That means they're updating their legislation. So go with what's there, roll the wheel down the hill. but be very respectful of what matters at country level. So actually, when you ask what's one of WHO's best buys on mental health, it's the regulation of pesticides. Because tragically, so many people take their lives using pesticides, very often a result of climate change and changing environment, which means that farmers no longer are able to farm the land that they have. So they resort to poison. They poison themselves. So in some countries, it will be actually as simple as regulating the quantity and the access to pesticide. But in other countries, and in most countries, in fact, it's worth thinking about some basics. So 75% of mental health conditions begin before the age of 24 and 50% before the age of 18. So in every country, child and youth mental health will be an effective best buy. That will be one of the things that makes all the difference. So I'm not going to go on because I feel like you've heard a lot from all of the panel and you haven't had a chance to ask any questions. So I'm happy to answer any question you might have. But as I said, two hands, it's physical and mental health, and it's listening to humans and listening for what actually the individual really needs. Thank you.
Thank you so much. Thank you so much for sharing. And I'm also already thinking about all the links you have across all the risk factors when you mentioned pesticides, and I wouldn't think about that in the context of mental health, and I just reinforce how everything is interconnected. And now we'll go to Nina. Nina, now we go to air pollution, which amounts to over 7 million deaths every year. How can the health community convince other government sectors to invest in interventions to improve air quality? And also the recently published compendium of WHO and other UN guidance on health and environment, including policy options to tackle air pollution. How can we connect these policy recommendations with Appendix 3 and the NCD response more broadly? And how can we leverage broader climate and health advocacy efforts also to reduce air pollution levels, including in the context of like COP28 and UNFCCC?
Thank you, Paula. I'm going to do you a favor and try and keep this very brief. Your blood pressure, we'll bring that down a bit.
Thanks.
And everybody else's blood sugar, because I know I'm the last woman standing between you and the reception. So bear with me just a few moments. Okay, NCDs and air pollution, it's the elephant in the room. It's not on the Appendix 3 list. And yet 7 million lives attributable, 7 million deaths per year attributable to air pollution is a really conservative estimate. We know that 40% of COPD deaths are attributable to air pollution, over a quarter of strokes, over 20% of cardiovascular deaths and global burden of disease of CBD, 20% of diabetes, 19% of lung cancer deaths, and there's emerging evidence about the causality with dementia and of course with mental health. If you live in an area of poor air quality, highly polluted, or an area that's at serious risk of climate change, then this is clearly going to take a toll on your mental health. So the interconnections are woven throughout the NCD community, frankly, which is why as Clean Air Fund, we're really pleased to see ourselves as part of the NCD community and to be looking forward to working alongside many of you in the coming years to really emphasize that this should be on the list, this should become a priority. Frankly, to be very blunt, the global health community, the NCD community, we cannot get to SDG 3.4. We cannot get to that life-saving target for 2030 without taking on air pollution. And sorry to be blunt, but we're not catching it right now, and we absolutely need to get there. Globally, in fact, right now, in terms of what donors are putting money into, philanthropies, development agencies, and so on, governments in particular, we are still undoubtedly adding fuel to the fire. The air pollution, global burden of disease is getting worse, and it's getting worse very, very quickly, especially in low and middle income countries, especially in Southeast Asia, and increasingly, as of the last 5 to 10 years, in Central and Western Africa as well. This is where we're seeing the most rapidly rising burden of disease from air pollution. Business as usual is a huge problem, as Anna and Nandita were saying on the previous panel, a massive problem. So we do an annual study, the state of global air quality funding, and we found last year that globally donors are putting 4 times more money into fossil fuel life extending programs, and in Africa it's 40 times more funding that is going to fossil fuel prolonging programs and fossil fuel investment as compared to projects that are going to improve air quality. So business as usual is a massive problem.
We need to start looking at investment cases, as your first question alluded to. What works? We need a recipe book for what works in different economic contexts. We need those best buys for air pollution. There's a lot across different UN agencies that already exists. So we're not starting from a blank page. There's a compendium at WHO. There's work that's been done by the UN Environment Programme. Investment cases, there's increasing demand from governments to the UN Development Programme for investment cases for air pollution actions. And maybe my final message is that this tide can be turned. It has been turned in some places. China doesn't have great air quality still now, but they have won back 2 years of life expectancy with their war on air pollution, as they call it, which was introduced in 2013. They've already won back 2 years with a package of targeted policy actions across sectors. So it's not a simple recipe book, and it's one that has to be tailored country by country, economic context by economic context, but it's one that can work, and it can also yield results very, very quickly. If you move a highly polluting factory or industrial facility, you start doing things on traffic pollution, emissions limits, and so on, or rerouting traffic for that matter, you can see good results in terms of hospitalizations for stroke, for heart attacks, obviously for asthma. You can see results within days and weeks. So these are investments that can pay back extremely quickly. And I'm looking forward to working with you all to
Thank you.
Together.
Thank you, Nina. And thank you for kind of final remark with some optimism. I will leave Alison now with a really difficult task to do it like in 2 minutes, Alison. It's you now. Thank you.
So thank you all for being here today and to hearing everything our speakers have been able to share with you. We started off with Bente Mikkelsen giving us a really clear overview of where we've got to with Appendix 3 and the reasons to be cheerful about their expansion and where we're going with them. It's now a live document and is going to grow. For us, this is absolutely key. This is a foundational document for when we're talking about the integration of NCDs into other big health themes, particularly into universal health coverage, the big theme for the year. And we were very pleased, we've heard today in the zero draft of the Universal Health Coverage Declaration that's coming out at the end of the year, NCDs are getting mentioned. So this is what we want to see implemented. So this is so important to us. So this is our essential package and it's great, but it can grow and it needs to be implemented. So great to hear from our lived experience colleague talking about the importance of how the patient voice and people's experience can really inform prioritization of the menu, what do you actually implement in country. But also it would be great to see WHO make progress in terms of developing a tool that will help countries go through that process of prioritization. So there's 2 different parts to that we'd like to see. And we also need to use all our voices to keep advocating for implementation. And we would love to see more investment in implementation science to really understand what works and then sharing that experience. And I'm really conscious of time, so I'm going to cut this short. This last panel is so important. We heard from Sarah about the importance of mental health and from Nina about air pollution. This is the true 5x5 agenda. And we would love to see that the growth of the Appendix 3, the best buys, grow to really embrace these and show the packages and build the cost effectiveness scenarios and the investment case to integrate these 2. So really important message from today. So like I say, we have got many reasons to be cheerful about NCDs today in terms of having a really strong package that we can be advocating to governments and how this will be the foundation of integration of NCDs into universal health coverage, our big messages for the week. I want to thank our panelists and I want to thank you all for being here today and for the people online who've been following this. I know there's not been enough time, so I hope you'll all stay around to have some questions during the break. And before I finish, but while I will invite you all to clap each other and the panelists. And afterwards, we're going to show a video which is all about our Global Week for Action and our campaign where we're trying to really build voice towards universal health coverage. So we're going to close the meeting and then we're going to run the video. So do stick around to watch it, but I didn't want to stop things further. So thank you all. And do please.
For political. This is the moment for political action. This is the moment for universal health coverage. This is the moment for caring. Join the movement online. Share your caring moment on Instagram or TikTok. It's simple. Create a post, reel or story. Use one of our filters and share using hashtag NCD Caring Voices. Want to get more creative? Add one of our stickers, easily searchable with an Instagram or TikTok. Your post is then picked up by our team and shared on our website. The moment for caring is now.